And this is the building where I currently work. It's called the Nisonger Center. And it used to be called UAP, a University Affiliated Program. And now we have new language, and we refer to these places as University Centers of Excellence in the Developmental Disabilities. And this particular center was named after Herschel Nisonger, who was an agricultural professor, and when he retired, he threw himself into his life's passion, which was learning disabilities. And eventually the center was named after him because of his activities in the area. One of our funders is the Administration on Developmental Disabilities, and they're the ones apparently who confer this label of UCEDD, or University Center of Excellence. This is some of what we do, operating clinics, family services. We have a number of programs now that are intended to help young people make the transition from high school into the workplace and things like that. I think that's really the wave of where we're going to be very, very soon in many areas. So we have clinics, interdisciplinary training. It turns out we also do disciplinary training, but that gets trumped typically by the interdisciplinary, and research. And that's the mandate for all UCEDDs. There are 67 of them across the U.S. Some states have 2 and some only have 1. And I think that's largely determined by the state's population. Okay, so here are some of the clinics that we have that you can see. We have an autism spectrum clinic, family-directed, Williams syndrome, developmental disabilities clinic. That takes all comers. Yes, ma'am.
What does it mean, family-directed developmental clinic?
Well, that's, I've never actually attended one of these clinics, but it's typically a single family and with several professionals there. It'll be speech and hearing, psychology, social work, you name it, special ed. And I think the implication is that it's a collaborative effort. I think it's intended to convey more than just a label. Williams syndrome, as many of you know, is a very rare metabolic condition. And the developmental disabilities clinic is more wide open. We really don't know what the handicap is that individual is presenting with when they come. We're unusual in that we have a dental program for people with disabilities. Dual diagnosis is the language that's maybe on the way out, but it implies presence of a developmental disability plus a psychological or emotional condition as well. The center where I work also provides all of the behavior support services for children, adolescents, and adults for the surrounding county, which has about 1 million people in it. So it's that is a particularly large service. That's kind of where I come from. I've been there since 1987, and I thought I'd talk a little bit about autism tonight. And I don't think that we're necessarily just locked into autism because these slides relate to autism. Because a lot of what I do is to look at the effects of medication. And there may be instances in which a medication effect is unique in autism. But I think it's probably more common that the effect would carry across to this whole range of people with developmental disabilities. And that's something we could talk about. So we're talking about autistic disorder itself, and then there's the so-called partial expressions, Asperger's disorder and pervasive developmental disorder, not otherwise specified. So with autism, we're talking about a qualitative impairment in social interaction. The person interacts typically poorly and often oddly with other people. And there's also a qualitative impairment in communication. I think we're gradually coming to realize that communication is really a reflection of category A, the social interaction, as often as not. We communicate oddly because we're socializing oddly. So that is probably going to be reflected in upcoming versions of the DSM. And then last, and certainly not least, being over-focused, having interests that are perhaps overly narrow, and activities that are repetitive and sort of non-productive because they are so focused, is the third symptom. So I'm not going to agonize over these. I thought I would just go to this slide, which is cutting to the chase, so to speak. So autism, if you say, we have all three. We have the social delay, we have the language delay, and we have the repetitive behavior. If we look down at Asperger's, language is not delayed. It may be wooden, it may be odd, but it's not delayed. And but the social impairment is there, and the repetitive over-focus is there. So that's, as the title of this slide says, plain and simple. A colleague of mine named Larry Scahill put this together, but basically I buy into it. And then in the case of pervasive developmental disorder, not otherwise specified, basically we're saying that there must be some social impairment there, and maybe language delay, and maybe repetitive behavior. Probably elements of both of them, but not sufficient to elevate to a diagnosis of autism. So they all look a little bit alike, but autism hits the trifecta. You've got all three of those features are there with the recommended number of symptoms on each one of those, categories. Okay, just some other aspects about autism. Early onset, by definition, it has to be before 3 years of age. There's a high male to female ratio. We typically, in our studies, see even higher than 4 to 1. And some of the studies that I'll show later on, the ratio has been as high as 8 to 1. Maybe that's because of what we're actually screening the children for. The current DSM says that as many as 70% of these individuals have intellectual disability. But Louise and I were talking on the way here, and as we all know, the rate of diagnosis of autism spectrum disorders is going way up. And as that goes up, it's very likely that the level of intellectual impairment is going to go down, because we're tapping more into that gray zone of kids who maybe 15 or 20 years ago wouldn't have gotten a look in by mental health professionals. Let's see, significant impairment in daily living skills. So if we do an adaptive behavior scale on these kids, the things that they can do to get through everyday life, the skills that we all need, drive to work, catch a bus to get from A to B, and so on. We find that kids with an autism spectrum diagnosis fall below where we would expect they would, even if we take their mental age into account. So they're performing below expectation, even when we adjust for their capability. Let's see, 25% may develop seizures. This has sort of been carried on through the decades. I'm not sure this is going to hold water in the next, from now into the future, because I think some of our older work may have been done in developmental centers where the level of physical and central nervous system impairment was much worse. It was very severe. So not surprisingly, we were seeing a high rate of epilepsy and seizure conditions. Let's see. And a high rate, I'm probably a little conservative in this slide, 35 to 45% have impairing other conditions like ADHD types of symptoms. And as adults, sometimes depression, anxiety, things of that sort. This again is stolen from a friend of mine, Larry Scahill. I'll blame it all on him. So we've heard about the prevalence rates. For autism, he kind of estimates 10 to 20 per 10,000 population. For Asperger's, 1 to 5. And for pervasive developmental disorder, 20 to 40, giving us an overall rate of about 4 to 6 per 1,000. Okay, why is it going up? Well, I think the rules have loosened up a lot. And why is that? Well, parents of these kids are often very articulate, they're well organized, they're well networked, and they've done a good job of educating the public. And that's the increased awareness that we're seeing. We, for the first time, have lengthy but very carefully detailed diagnostic tools to help us diagnose autism spectrum conditions. In developing those tools, they had to lay a label on what really qualifies as a symptom. And in doing that, I think it actually caused some clinicians to relax their, quote, standards, to broaden the criteria somewhat. Clearly, there's a greatly reduced stigma associated with it. People these days are not ashamed, nor should they be, nor should they ever have been, to have a member with autism in their family. There's been a broadening in the special education laws, and we have people asserting very loudly that they can improve the lifetime condition for kids with autism spectrum condition, especially if they can get in early on. What some people call low-VAS treatment or ABA treatment. The claim, the strong claim that's being made is we can reverse this, at least in part, with early intensive intervention. So all these things have led people to want to identify it when it occurs. So there's this report by Crowan et al. Out of California, using the California database. And what they found when they looked at the data in California was over a 7 or 8 year span from 1987 to 94, they saw approximately a 9-point drop under this autism column from 5.8, or an increase from 5.8 to 14.9. 5 units increase and a similar decrease under the intellectual disability. So people, what Crowan are suggesting is that some of these are the same people, but they're being identified differently within the system. So let's take a look at that. So the top curve would be the intellectual disability curve, and then the bottom one would be the autistic disorder. Okay, interventions. I think this is something that sometimes people like me who research psychotropic drugs, sometimes we get carried away with our own area. But when we're talking about developmental disabilities, we're talking about a condition where education is the core, should be the core of the approach toward therapy for these individuals. So first and foremost, our intervention should be educational, often behavioral, to address both the core elements of autism, or if it happens to be other developmental disabilities, other impairments that they bring to the table. And lastly, when appropriate, medication. So this would be problem behaviors. And some pharmaceutical companies and serious investigators are seriously looking now at the prospect of trying to reverse the core features of autism, actually attack the fundamental condition, which would really be interesting if we can pull that off. So one of the things I've busied myself with over the years are these medication surveys. And this first survey was done in '93, and then the other two surveys were done about 10 years later. So the first one was done in North Carolina, which is well recognized in the U.S. as one of the states that has the best services for people with autism and autism spectrum. And back in 1993, about 30% of individuals from the youngest to the oldest, we didn't really break it out by age, about 30% were taking psychotropic medicines. The anticonvulsants which show up in this slide are not included in that. They are separate and were given for seizure conditions. 10 years later, the rate went from 30% to about 45%, both in the state of Ohio, the middle column, and in North Carolina, the rightmost column. So it's interesting that Ohio and North Carolina are really closely paired in terms of the change that we see with time. What the heck happened? Well, the SSRIs came on board, and the second generation, or the new atypical antipsychotics, came on board. A lot of these medicines are considered better or safer, and I think one thing that happened is that we became more comfortable with them. Maybe it was some of the claims that were being made for them as well. We now know that one of the claims that was made for the SSRIs maybe isn't right. At one point, we thought we could manage repetitive behavior with SSRIs. There have been two big studies that have come out in the last couple of years, and neither one could find any signal there. So that's kind of interesting. So we're seeing an increase in a matter of 10 years, a 50% increase there. I don't think it's a blip. I think it's real. So what would a basic diagnostic evaluation involve? An interview that looks at the features of autism, a decent individualized IQ test, it's not a quickie test, an assessment of adaptive behavior, what that person can do in his or her daily surroundings, what they can manage on a day-to-day basis, language ability, hearing tests, some sort of review that looks at behavioral and emotional symptoms over and above the autism per se. Let's see, developmental review of the child's history, family history, and medical history, and finally physical exam. These are some of the conditions that we see the most across the lifespan in individuals with autism spectrum. ADHD would be probably the most common. Oppositional behavior, I'm not sure everybody's comfortable calling it that, but we see behavior that's certainly difficult to manage. And then as the person gets older, we may see manifestations of mood, like either anxiety or depression. And some of the repetitive behaviors really can be quite difficult to distinguish from obsessive compulsive disorder. So not surprising that made its way onto the list. Here's one of the first networks I got involved with. It's called, we can't invent anything in the U.S. without giving it a neat-sounding acronym. So this one was called the Research Units in Pediatric Psychopharmacology, or the RUP. And the mission of this group was to work together doing medication studies in autism. And so we had Indiana University, Johns Hopkins, OSU, Yale, UCLA. We had National Institute of Mental Health itself. And so we had several players involved here. The first study that we did was an 8-week trial, and it was with kids who had autism. And we required, for entry into the study, the clinician had to say the symptoms are significant enough that it really warrants treatment with an atypical antipsychotic, with a medication. It's the acting up symptoms are sufficient to justify the trial of a medication. And that's basically what a CGI, Clinical Global Impression of 4, means in this context. The greater than 18 irritability score, it's a parent-completed scale, and it includes stuff like temper tantrums, rapid changes in mood, aggressive outbursts, self-harm, yelling, screaming, shouting, that kind of thing. And the children had to be medication-free. I'll invite you to follow that dotted line down. We'll go from the 101 subjects at the left side of the screen, and you'll see they get randomized to either risperidone or placebo for 2 months. And then at the end of that period, they were categorized either as a responder or as a non-responder. Then if we stay with the placebo group, which is down at the bottom there, and we follow it to the across, those who were non-responders to placebo were then offered the opportunity of taking the active medication. And at that point, it's an open trial. Everybody knew what the child was getting. And if the child responded clinically at that point, he or she was designated as a responder or a non-responder. The non-responders were actually exited from the study, and we tried to maintain the responders for an additional comparison, which I'll show you in a few minutes. So at this point, everybody has been exposed to the active medication, in this case, the active medication being risperidone. Some of you might recognize it as Risperdal. And they would have received it for 8 weeks. Okay, so what was a positive clinical response? They had to be improved as rated by the parent by at least 25% reduction on this scale called irritability. Plus, the clinician assigned to that child had to conclude that the improvement was either much or very much improved. We typically work with a 7-point scale, which goes all the way from 1, very much improved, minimally improved, no change, minimally worse, very much worse. So in order to be considered a clinical responder, someone had to end up in one of those top 2 classifications, much or very much improved. And we ended up with 101 children, 4-to-1 ratio boys to girls. About half got risperidone and half received the placebo. They were about 9 years of age on average. And this is as good as it gets in medication research. So we see the top curve represents the scores for the children who were randomized to placebo. And the bottom curve represents the scores for the children who received the active medication, Risperdal or risperidone. The straight lines, that's just what scientists like to do, is put straight lines through everything. But that bottom curve represents a 58% drop, which is a big drop. And these are done by blinded parents. Parents have no way of knowing whether their child's on the active medication. If we look at the irritability line here, which is highlighted in yellow, you can see that the reduction there is 57% for the active medication, and it's 14% for those on placebo. So you get a little bit of bounce from the placebo, but not enough. And then if I want to cherry pick here, the level of repetitive behavior or stereotypic behavior was also fairly markedly dropped from about 10.5 to 5.8, and not much change for the placebo group. And then hyperactivity showed a fairly sizable drop from about 32 to 17 for active medication and about 32 to about 28 for the placebo. So something's actually happening, and that's about as good as it gets in this field. So here we see the blinded clinicians' ratings on the Clinical Global Impression Scale. And the upper curve is the percent of children on medication who are judged to be much or very much improved. And the lower curve is the percent of those taking placebo who are judged to be much, very much improved. You can see there's quite a sizable difference there. And then we should never talk about medications without sort of displaying some of our dirty laundry. And here's the biggest problem and the most consistent problem we face with this particular medication, the price to be paid in many individuals is weight gain. A lot of individuals experience a ravenous appetite, a compulsion to eat, a need to eat, and that's a problem. There's a little bit of grace in that curve because you see at the end it dips a little bit. So it appears to reach a point and not go above that point, but nevertheless, it's an issue because weight issues are already a problem in our society, and we don't need to add to them. So this is one of those side effects that causes a lot of anguish by doctors and by parents. Okay, then we did something kind of cute. You don't see this very often in medication studies, but this was a discontinuation or discontinuance trial. And what we're going to do is follow that dotted line to the right now. Now remember that everybody at this point has been exposed for 2 months or 8 weeks. And what we did is we asked the families to continue with the medication for another 4 months. So 4 plus 2 gives us 6 months exposure. And then we asked the parents to do a very difficult thing, namely to agree to be re-randomized. And what does that mean? That means there's a 50-50 chance that we'll either switch the medication to placebo or we'll keep it as risperidone. And the way we did that is we had a series of vials with medication in them. And on the first week, we said, take 1 pill out of here, the rest of the pills out of here. And so the first week, if the child was in the discontinuance group, the dose was dropped by 25%. So in the first discontinuation week, the discontinuation group is getting 75% of their previous medication. By the second week, it drops to 50%. By the third week, it's down to 25%. And by the fourth week, it's 0. So by the end of 3 weeks, the child is down to 0. And this is a hard thing, to ask families to do, but most of them did it. Most of them agreed to do it. And so we had 63 children whom we followed out for the additional 4 months. And we lost 5 of them because they seemed to eventually lose the benefit that they had previously shown with the risperidone. So 5 of them dropped out. And this just shows us the irritability scores over that time. That, believe it or not, is statistically significant. It's actually a significant increase in symptoms, but clinically it's trivial. So it's just there to give you a feel. Nothing much is changing. And this is a picture of the doses, and those are also increasing significantly, but again, once again, clinically the changes are trivial. And then the end of the trial re-randomization, as you know, there's a 50-50 split. What I didn't tell you is that there were planned interim analyses. The government is very anxious about discontinuation studies because it implies we're taking away something that worked. And so we try to put in place as many checks and balances as we possibly can. So what we had is we had an interim data analysis after the first 16 children went through, and if nothing popped up, statistically significant, and we continued. And then we did another interim analysis at 32. And here's what happened. At 32, the group of professionals looking after this study said, stop, you will not enroll any more children into the discontinuation study. At that point, it became perfectly obvious what was happening. As you can see, we had a 64% relapse rate in the group of participants discontinuing treatment. And we had about a 14% relapse rate. So that's kind of repeating the evidence, so to speak, at a later point in time in these youngsters. So it suggests that the treatment, for the most part, still continues to work out at 6 months. And apparently the relapse rate was 12.5% in children who continue to receive the risperidone, and it was 62.5% in those who got randomized to placebo. Here's another study the RUP group did, namely a look at Ritalin, good old-fashioned Ritalin. There was a time the media could never let that one go, but they've given up on Ritalin. They've moved on now. So we wanted to look at Ritalin because it is the kind of the standard of care for ADHD symptoms. And in this particular trial, we were looking at children on the spectrum who also happen to have ADHD symptoms. And so we started out with 72 children. You can see they were roughly 8 years of age on average, mostly boys again. What do we have there? About an 8-to-1 ratio. And mostly autism, although a few with PDD-NOS and a few with Asperger's. And this is exactly what you want in a study like this. What that spike shows us is that as rated by parents and by teachers, the teachers are the yellow bars and the parents are the blue bars, as rated by parents and teachers, these kids are perceived as very overactive, inattentive, and impulsive. Okay, I wish I had a pointer here because what I'd show you is the real action here as we look at these bars is the difference between the baseline and the placebo. That's the biggest drop. Now, these children received all conditions. So they received the baseline first and then scrambled up in any order. They received a low, medium, high dose of Ritalin and placebo in any order. And what we see is the biggest drop is between baseline and placebo, and then we get a smaller drop between placebo and the active medication. So the active medication is doing something, but it's not as impressive as when we go into the actual trial from baseline into the to start taking pills. So once again, we use the CGI, much improved or very much improved, scores of 1 or 2 to identify children who are responders, and a decrease in symptoms by at least 30%. And what do we get? We get 20% having their having a clinical response to placebo, 33% to the low dose, 34% to the medium dose, and a little wiggle room here. I won't go into it right now. More like 30% on the high dose. Now, of those who were known to respond, their best dose were the 4 that we have listed here. 20% had their best dose to placebo, 25 to low dose, 32 to medium, and 23 to the high dose. And here are the teacher ratings. Again, you've got that fairly sizable drop from baseline to the placebo condition, which could have been the second, the third, the fourth condition, and but some reductions with the active Ritalin. And variability is the rule here. So you'll have some kids who will show you quite an impressive improvement. The next child might show you no improvement at all. Okay, irritability ratings by the parents and by teachers showed no real change. Social withdrawal, interestingly, with the high dose, as rated by parents, it was significantly worse than placebo. So too much of a good thing is not a good thing. So we're actually able to show a tendency to withdraw socially if the dose gets too high. In this study, we didn't even admit the children until they had test doses. And so they had a couple of days at a very low test dose, a couple of days at another test dose, and finally at a higher test dose. There were 6 children who were unable to get through the test dose phase. And then 7 dropped out of the crossover study. That's basically a design where everybody gets each of the treatments. And so we have a total of 13 out of 72 who were exposed to methylphenidate or Ritalin who dropped out because of side effects. And I'm going to show you a couple of those side effects. Here are ratings of irritability. These are percentages. So about 12% had unacceptable irritability ratings with the medium dose. And about 13 or 14% had unacceptable emotional outbursts during the medium dose. And then this is the grand summary, the pie chart that shows us everything that happens. So the white space at the lower right-hand corner, just about 50% responders to Ritalin, methylphenidate. We had 13% who were placebo responders, 19% who didn't respond to anything. Apparently one child just didn't comply with the study procedures, and another 18 who couldn't tolerate the study medicine. So this is a picture that's worth 1,000 words. The MTA is a great big study that was done in the US with 600 participants, typically developing children. And what we see with the MTA kids, the orange graphs, we see that we get this big effect size as rated by teachers in typically developing kids. And we get a much smaller effect size with teachers. What's an effect size? It's basically the amount of punch, the amount of benefit you get from the treatment. So in the case of teacher ratings, it's an effect size of 80 as compared with, let's say, 35. In the case of parent ratings, it's roughly 70 versus 0.5. And let's see, the response rate was in the mid-70s for typically developing kids, and it's just under 50, as we already know. And then look at the intolerable side effect graphs. We've got approaching 20% in the RUP study, and something like 3 or 4% in the MTA, the typically developing kids. Yes?
You told me that in the MTA study they gave all of those children Ritalin?
Yes.
And did they do it the way they did it in the RUP study?
No, it was not done identically.
And how much Ritalin were they given?
You know, I'd have to go back. I think in the MTA study that they titrated, which would mean that they kind of individualized the doses, whereas in the RUP study, we kind of went with standard doses. Usually if you titrate, you can do better because you individualize and get what suits that child, you know, the best. So that's a good question. But it's kind of there to make a point. It's not to say, now if somebody asked me what would I recommend for a child who has ADHD symptoms and who happens to be on the autism spectrum, I'd say start out with a stimulant like Ritalin. Because you know what? It may not work, but we know a heck of a lot about it, and we know it's pretty darn safe. So, what people have to be aware of is that the likelihood of a less than satisfactory response or side effects that we don't like goes up as the child moves into the autism spectrum. So the equation changes. The risk-benefit equation changes, but it's still not a bad equation. We still know that there's a 50-50 chance that these kids will have a positive response. Feasibility of behavior intervention. Can we do better? Are medicines the sole answer? Well, who wants to say it is? The medicines are the sole answer. So what we decided to do was look at Ritalin, or excuse me, risperidone, at this point we've had a lot of experience with, and add a psychosocial treatment. And in this case, we chose parent management training, PMT, basically behavior intervention as practiced by parents, as taught to parents. So the design, it was intended as a 6-month trial. We had planned to enroll 120 children into this study, and what we ended up with was just under 50 who were actually assigned to medication only, and 75 who were assigned to the combination treatment of medication plus parent management training. There's a schematic of the study. So basically, at baseline, everybody was screened, they were randomized, basically 60-40 ratio, and so 75 eventually got the risperidone plus behavior intervention, and we followed them for 24 weeks. And the parents in this study received one-to-one sessions with behavior therapists, most of whom were PhD psychologists. Forgot that down at the bottom here we see outcomes are compliance, irritable behavior, and adaptive behavior. Okay, we ended up with, we chose to include boys and girls between 5 and 13 years. They could have any autism spectrum disorder. And again, just because of the way we had selected people in the past, we chose an 18 or higher on the ABC irritability scale. As in the past, they had to have moderate score on the clinical global impressions. They had to be medication-free when they started, and they had to have a certain minimal IQ for enrollment. So we had 3 outcomes of interest. We focused on irritability because we knew the medication worked for that. We also focused on noncompliance. We actually hoped that the behavior intervention would have its biggest impact on adaptive behavior. So our thinking was that if we could get the noncompliance and irritable behavior out of the way with the medication, and have the parents there as the instruments of change, that we had the capability of elevating up these adaptive behavior scales. So we had an interesting situation where the target for the medicine was irritability, and the target for the behavior intervention was adaptive behavior. And the middleman, so to speak, was going to be noncompliance, improvement in noncompliance. So these are sort of key elements to it. No placebo. We didn't feel good about just assigning kids to placebo after we'd already demonstrated those huge changes you had seen earlier. No PMT only. So there are some people who felt it was unfair not to have a PMT only. We didn't see this as a beauty contest between behavior intervention and medication. We saw it as asking the question, how can we get the most improvement for these kids? And so we actually had, in several ways, 2 or 3 outcome measures of interest: the irritability, the compliance, and we thought the compliance would be the road to improvement in adaptive behavior. So there it is again. How many times can I say this? It's basically reorganized slightly different way. Our thought process, the low intensity, and this is low intensity compared to some behavioral programs. There's only so much we can ask busy parents to do. And so we didn't feel it was fair to pit one against the other. And so basically we said, what is the additive effect? And We decided not to focus our treatment outcome insofar as PMT. We were not going to hitch our horse to irritability or the rating. The ABC ratings were more focused on adaptive behavior. It's somewhat ironic in how this whole thing unfolded. So our objectives, we had to develop a manual because there was no manual that really suited our group, which, by the way, included a large number of behavior therapists and pharmacotherapists. We had to review issues related to maintaining fidelity. We had everything in place you could think of to go over homework. We had videotapes showing, sort of demonstrating how to screw up behavior therapy. We had other examples of how to do it brilliantly and so forth. And so the behavior therapists worked very carefully with the parents on these. We went after an intervention that was empirically supported, that could be used across many different sites. That that wasn't going to fall apart if we moved it from if there was a team at OSU, they'd be using it differently than, say, a team at Yale or things like that. It had to be multidimensional and be capable of addressing a variety of targets. It had to be capable of showing an effect over the time frame chosen, the 6 months, and we had to be able to train people in multiple settings. And the winner is parent management training, which you already know. These are some of the reasons. It's history, very long established literature on this form of behavior therapy, used in many of the intensive preschool programs now. I talked earlier about intervention and being able to alter the course of core autism features. It's these kinds of programs that have been used that are making these claims. It's easily transportable. What does that mean? It means we can train people outside of the doctor's office, take it into the home and use it. It's cost effective because it's not some highly paid professional, it's actually a family member that is implementing the program, and it can be implemented nearly anywhere. So obviously, just like a medication, it has its limitations too. We were afraid it might not be intensive enough. There was no manual that did what we wanted it to do. We didn't know at the beginning anyway how we would individualize this so that it could be adapted to boys, girls, multiple ages from 4 to 13, different IQ levels and so on. And obviously the parent had to be able to put these principles into effect. So there were a lot of issues. And so these are the elements that our behavioral group focused on. They wrote this manual in a matter of a few months. And basic ABA principles, reinforcement, folks who have been exposed to behavior intervention will recognize all of this stuff. Functional communication, teaching strategies, generalization and maintenance, and so on. So what happened? Really, this just shows that there's no difference in the kids who are assigned to the med-only or the combined groups. Same story here. The clinical global impressions, they were much the same in the eyes of the clinicians when they started out in terms of the problems and so forth that they might have had. Here is, this is the verdict. So on the, this HSQ stands for Home Situations Questionnaire. And what we see is a reduction that doesn't actually show up until week 24. And it's, we're seeing it in the combined condition, which of course is where we would want to see it. And then the ABC irritability also showed it. You can see basically about a 3 to 4 unit difference at endpoint. And let's see, the next one that shows something is ABC hyperactivity. The kids on med only go from 36 to 21. and the kids on combined go from 35 to 15. So there's a reasonably large effect there. Now this is the curve that shows all the data, and it's really quite surprising. We're not getting an effect until we're out at about 16 weeks, and then those curves start separating. They are a slightly different color. The red curve actually is the med-only group, and the black curve is the combined treatment. And the combined treatment actually starts being scored higher, indicating that they actually had slightly more serious problems at the beginning, and at the end, of course, they're lower. There was actually an IQ difference between the two groups when we started, and so we took that into account. We analyzed every way we could. It didn't make a difference. Basically, regardless of how we analyzed, we got that same effect. This kind of shows you the nature of that effect. For irritability, we start to see separation at week 16. At week 24, it's a little more noticeable. For hyperactivity, noncompliance, we're seeing it again in a similar way. And here's a kind of unanticipated little bonus that comes along with this. These are doses of risperidone. Now, the clinicians were told, push the dose. Even if the kid is doing well, push the dose. And because we wanted to the extent possible, equalize the medication conditions. We end up at week 24 with a significant difference in dosing, where the kids who received the combined treatment had about a quarter milligram, a little bit more, less medication. So that's kind of just one of those things we didn't. So basically we saw improvements on this compliance measure, on this irritability measure, and on the hyperactivity noncompliance. You already know what we were hoping for with adaptive behavior. We put all our money on activities of daily living, daily living skills. That's where we thought we were going to see our effect. We were lousy guessers. We did not see a statistically significant effect there. In fact, it was very small. We didn't necessarily expect to see it here, and this is where we did see it, on socialization. The kids were socializing better, responding better to the normal social overtures and that kind of thing. And then, if you believe in almost, we have a probability value of 0.6, which is normally rejected as not significant. I do believe in almost. So we were seeing some improvements on this communication domain of the adaptive behavior scale. And that's where I'm going to leave it. Those are some of the studies we've been involved in.